Hi, I'm Sherry Allen, and I'd like to welcome you here tonight for the presentation with Dr. Nancy Evans on the nuts and bolts of thyroid. If you've ever had any questions or confusions about this subject, she's going to clarify that tonight. So stay tuned, and the presentation will begin shortly.
Tonight's chat is brought to you by ThyroidRx and Haltraceuticals.com.
So I went to my doctor and she recommended I try all these thyroid medications. She mentioned something about armor. Is that something I wear? I'm confused. Does it protect my thyroid? Thyroid? Is that in my head? I don't even know where that is. TSH, T3, T4. What is that? Does that go in my coffee? I'm not sure. Maybe I just need to go get a latte. T3? What is that? Math? I failed math. Isn't that like T3 3 times from 1? T4? Is that 4 times T1? TSH? What is that? Is that like for texting? I don't even know what it means. Maybe I should check Twitter. Thyroid nuts and bolts. Do you have nuts and bolts in your thyroid? I thought they were in your car. Wait, or are they?
5, 4, 3, 2, 1.
Good evening, everybody. Welcome to Health Chat number 5. I'm Dr. Nancy Evans from Holtorf Medical Group. I want to remind you of my purpose for giving these talks, and it's to help you achieve optimal health so that you can live out your life's purpose. And you absolutely must find a doctor who's willing to join you on this venture. If you find somebody who's health, and I don't want you to settle for anything less, okay? Tonight's topic is thyroid nuts and bolts, so let's get started. So the thyroid, it's a gland located at the base of the neck, and it has the power to turn on the ignition of your body. The thyroid hormone is the key. It literally goes into the nucleus, which is the control center of every single cell in your body. And what does it do when it gets there? It controls the metabolism, meaning the rate or the speed at which that cell performs its function. So it affects everything in the body. When our thyroid is functioning optimally, we have good energy, we have good metabolism so we can control our weight. We have healthy brain function, meaning focus, concentration is sharp, and good moods as well. It also affects those neurotransmitters. And we can control our weights. We have good metabolism that way. And actually, primarily, it also keeps our body temperature up. So that's when the thyroid, the gland is functioning properly, and the molecule, the thyroid hormone, goes into every cell in the body and it works perfectly. What happens when your thyroid is not functioning perfectly? Let's look at the example of hyper. That's when it's too high, hyperthyroid. When we have hyperthyroidism, by the way, this is very rare. We'll talk about some conditions when it happens. So think of it's a little bit like in your car. So the engine or the idle is turned up too high. So your metabolism is running too fast. So the body temperature comes up. We have actually weight loss because you're burning calories too fast. Sometimes it even happens with digestive symptoms. So you're hungry, maybe even having loose stools. It's like the fuel is coming in, using up, burning up. Same thing with your car. It's like it's burning up the gas or the oil. And also there's this hyperactive feeling. The heart is actually usually beating too much. And we see somebody having increased heart rate or maybe going into an irregular heartbeat like atrial fib or AFib. So that's hyperthyroidism. As I said, this is more rare. I'll talk about a few conditions. What we most commonly see is hypo. So how does this work? If your thyroid is not working properly, then we don't have enough of the thyroid hormone. So again, remember I said it's like the key going into every cell. So we don't have enough keys. So what does the body do? It says, let's conserve energy. Let's just do the functions of the body that are essential. So let's continue to make the heart beat, and let's keep your organism, keep you breathing, and just keep you alive. And the body says, how else can we conserve energy? Let's cut down on those tasks in the body that are non-essential. So what do the symptoms look like? The low body temperature, right? So we get someone with cold hands and cold feet. If you wear socks to bed, there's a good sign that you're hypothyroid. This is one of our classic signs or symptoms of hypothyroidism. If you're the person that's always putting a sweater on when you go out with friends, you have that low body temperature. We have husbands and wives. The wife are always freezing, and so she might be low thyroid until she goes through menopause when she has those nighttime hot flashes. Then she's the hot one. So we have all sorts of body temperature issues going on with thyroid disease. Then what else happens? We have dry skin, right? That's not an essential function of the body. So we have cold hands, cold feet, dry skin. The heart rate might be a little bit lower. We also have slower metabolism, so we often see constipation with somebody with hypothyroidism. It's a very common symptom. Slowing down that metabolism, what else does that mean? It means that the body's trying to conserve energy, so it's only burning a fewer number of calories every day. So that person cannot lose weight. This is the person who has been eating the same their whole life and is exercising the same, and all of a sudden they start putting on 20 pounds. So these are the typical signs of hypothyroidism. We also see the brain function going down. So we see brain fog, sometimes even lower memory or inability to focus. We also see depression. So it really can affect the brain. And it also can affect the immune system. Again, the body's trying to conserve energy. So it says we don't have time to fight off a cold or a flu or a virus. So we get people that are starting to have colds. They say, I never used to catch colds. And now they're getting them once a month, or they're getting them every time their kids come home. They're starting to catch their cold or flu, and that never used to happen before. And of course, this fatigue. That's the main symptom, of course, of hypothyroidism. Mainly this person is sleeping too much, never feeling rested. Occasionally with hypothyroidism, though, we'll also get somebody who says, I'm getting insomnia at night, right? So these are some of the typical pictures we see of hypothyroidism. Now, how do we diagnose thyroid disease? This is a really important issue. If you go to your primary care practitioner, or sometimes even an endocrinologist, you will report these symptoms and they say, okay, let's check your thyroid. They will check one lab and one lab only usually, which is called TSH, or the thyroid stimulating hormone. If you haven't done this after you watch our video tonight, watch the one that we did with Dr. Holtorf called 17 Years Ahead. And he explains this in depth, that this test is not the most reliable indication of hypothyroidism. I'm going to talk about all the lab tests we will order. But that's basically what your doctor will do. And remember, they only are spending 10 minutes with you, so they're going to say, oh, yes or no, you have hypothyroidism. We here, and you should make sure you find somebody who does this kind of diagnosis. We have 5 ways of diagnosing you with hypothyroidism or hyperthyroidism. So either dysfunction of the gland. First, we listen to you. If you don't find a doctor who will listen to you, again, they're not doing their job. There's no way that they can diagnose you properly. So we listen to you. If you say, yes, I'm only eating 1,000 calories a day, we believe you and we understand that you're having some changes, so probably something is changing in your body and it's not working optimally. So that's the first thing. Those are symptoms. So I listen to your symptoms. You say, I'm cold, I'm depressed, I put on 20 pounds in the last 6 months, things like that. So those are the symptoms. And we also have something called signs. So signs are when we, as the medical professional, look at you. So it's through our observation or our touch. And some of the signs of hypothyroidism are puffy eyes, swollen, puffy neck, sometimes even the ankles too. So we get this edema. And it's because the thyroid, the liver actually cannot, it doesn't have enough thyroid going to function properly, and so the liver cannot make the adequate proteins in order to keep your, it's really part of the lymph glands actually, so it's not keeping this kind of balance going, so you have this puffiness, and that's not quite the weight gain, but it's that water retention. We might also see, as I said, big circles under your eyes, or you've told us that you've had hair loss, and then we might see that there's thinning. When we shake your hand when we meet you, we see that you've got cold hands. And we also see that you're obese or overweight, especially if we saw you 2 years ago and your weight was well balanced. So that's 2 ways that we start to diagnose you, with your symptoms that you report to us and the signs that we observe. The next are lab tests, of course, which we will order. So the day you come in to see us, we will order a full panel of lab tests, which I'll go through in just a moment. We have 2 other ways that we diagnose, and one we call it advanced testing. So we looked at you physically. We also do some aid with some computers actually to help. What we're trying to do is see if your metabolic rate seems like it's slow. So we have a test called the basal metabolic rate. We have you breathe into an apparatus and we see how many calories are you burning at rest compared to what you should be. This is a really interesting test. As I said, it's called BMR. So what will happen after you do that test, you'll breathe in this tube for 10 minutes and we get some calculations. So it'll say estimated, let's say it's something like this. So it'll say your estimated basal metabolic rate. So what we're trying to do is mimic your basal metabolic rate at rest. So if you were to just lie in bed all day, what would be the base number of calories that you would burn in order to just stay alive before you exercise, before you go to work, before you perform any bodily functions? So we'll say, we'll do some the machine does the calculations, and it'll say your estimated basal metabolic rate, this is just an example, is 800 calories a day. Then we find your test, say your results comes out to be 1,300. And by the way, these are pretty typical numbers. We see this all the time. What does this mean? This means that without treatment, your basal metabolic rate, you are burning this is calories by the way. That without any treatment, you're burning 500 calories less per day than you should. And I know I'm hearing a whole bunch of ahas right now, right? Because we tell this to our patients, they say, I know, I promise you, I've only been eating 1,000 calories a day and I'm not losing weight. My other doctor said, oh, you must be getting up at the middle of the night binging. It's not true. Because the thyroid is not going in and turning on the metabolism of every cell in your body, your metabolism is shut down and you are not burning these calories. So what this is telling us, these are all add-on tests that we do in addition to your blood test, really to prove the point that your body is in a hypothyroid state. So the other advanced test we do is we also measure a reflex. Studies have shown that one of the best markers of testing for or diagnosing hypothyroidism is looking at your reflexes. So we test it on the Achilles, which is in the back of your ankle, the heel, and we do it that way. Then with the computerized test, we test your brachioradialis muscle, it's this forearm muscle, and what we're measuring is the relaxation phase of the reflex. So the machine hits you here and then measures the relaxation phase. If that is slow, it means that you have a slow reflex, right? A slow metabolism. And this is one of the clinical signs, meaning what we see and observe in you, of hypothyroidism. So now we're starting to paint a really complete picture of your body's state. The third test as we do is urine iodine, because the thyroid hormone needs iodine to function. So now we've got 3 points of observation to see whether to diagnose you with if you have thyroid disease. And then the other one is imaging. We don't always do this, but we're starting to do it more and more because we're finding some more and more pathology here. So imaging means an ultrasound in this case. So the ultrasound technician will look to see, what does your thyroid gland look like? Is there any dysfunction in there? Is there cellular growth? Is it enlarged? In earlier last century, we would see a lot of goiter in the Midwest. They didn't have iodine in their water. If you don't have enough iodine, the thyroid, again, it's just trying to cope, and so it creates this extracellular growth trying to function. So you've probably seen those classic pictures of the really swollen neck. So that is something that would show up on the imaging. This will also help us diagnose if you have an autoimmune condition. We also do need to rule out any pathology like cancer, and there's certain parameters for that. If we see cysts, it's quite common, but if we see nodules, again, that's pretty common. But what gives us concern is if a nodule is larger than 1 centimeter, if it is solid, meaning not sort of liquid or filled like a cyst, and if it has an independent blood supply to it. That's always a possible sign of cancer because these cells are working independently and they're not shutting down the way they should. So they're continually growing, and perhaps it's a tumor that's growing. So we always want to rule this out and see if this is part of the picture when we're really diagnosing, if we want to do a complete job of diagnosing your possible thyroid disease. What's interesting about this, especially when I'm listening to you speak, is occasionally I'll get somebody who has a gravelly voice. I'm not talking about postnasal drip or kind of like a cold or a hoarse voice, but it's a gravelly sound, kind of is a rough edge like a serrated knife. And this is also a possible sign, something that I observe, of hypothyroidism. Because if your thyroid is enlarged, the extra cells, they're pushing against the vocal cords, and so it's making your voice sound different. And I'll ask patients this, sometimes I can just hear it, it's quite blatant, or I'll ask them, do you ever feel like you have a gravelly voice? Or, in addition, there's some difficulty swallowing. They'll say, yes, I can't swallow pills. Or they say, yes, the last few months I just feel like there's something caught in my throat. So that's some real kind of gross pathology happening at the site of the gland, and then it's probably producing some dysfunction at the level of the blood, and so it's affecting the rest of the body. So the last is lab tests. And this is going to be a big discussion here, so let's get into your lab tests. Okay. This is the brain, especially we're talking about the hypothalamus and the pituitary. So these are the control organs of our body. And they actually oversee our ovaries and testes, so the sex hormones in male and female. They oversee the thyroid and they oversee the adrenals. So it's always, our body's really nicely tuned. We have this checks and balance. So up in the pituitary, our brain produces TSH, thyroid stimulating hormone. And this is our checks and balance. And the range for here, the normal range, is between 0.5 and 4.5. Now this one works in opposition. If this number is high, it means you're hypothyroid. And why is that? This is the brain. How loud does your brain have to signal your thyroid to do its job? How loud does it have to yell at your thyroid to do its job? If it's high, way up here, you're hypothyroid. And if it's low, theoretically, you're hyperthyroid. But let's look a little bit further. So as I said, when you go to see another doctor, most likely they're just going to look at this normal range and say, you can't be hypothyroid. It must be something else. You must just be depressed. Even though you've gained weight, your hair's falling out, you have cold hands, cold feet, and you're depressed, right? Let's talk about normal labs first. So this is industry-wide. It's just the way the medical laboratory standards have developed over time. When a lab takes in all of the samples when it's testing, so say it takes in 100 samples, and just as an aside, who gets their blood drawn? Usually people who aren't feeling well. Now, of course, when we do clinical research, they'd compare it with healthy controls, but typically a lab, you only get your lab drawn when you go to the doctor, and you only go to the doctor when you're not feeling well. So right away, if we take all these samples from the population, we're sampling from a sicker population, so those numbers are probably not optimal. So say this lab takes in 100 samples. By definition, they take them all in, they do some statistical graphing, and they take in the mean plus 2 standard deviations away, and they call that normal. It's basically a bell-shaped curve, right? And this is normal, and it's 95% of the population. So in a lab test, if you're at the top 2.5% of the population or the bottom 2.5% of the population, that's the only time they will call you your lab test abnormal. So how many of you have gone to your doctor and said, I know I have all the symptoms, I go to my doctor, they say it's normal. So let's take a nice analogy here to the academic world. So this is, because we use bell-shaped curves, right, in grading. So in the academic world, we're basically saying we're only going to worry about you or notice you if you're in the bottom 2.5% or the top 2.5% of the class, which means we're only going to say something if you're an A+ or an F. What happens if you slid from an A- down to a D+? That is a huge change in behavior or health in this matter. And either way, the lab and the doctor would say, that's normal, go home, it can't be your thyroid. So right away, our normal values are really only looking for basically to keep you out of the emergency room. And that's what we've talked about, normal values. So what we're looking for in general in most of our labs is at least the top half, the middle range. Now, ideally, we'd love to get lab tests when you are feeling great. When you come back to the doctor 5 years later, we see that you did slide down from the A- down to a D. Or maybe we see your lab values and you're right at normal, you look like you're a B+, that could be fine. But again, for you, maybe that wasn't optimal. So there's a lot of things to think about here in these terms of lab tests being optimal versus normal. And this is what your primary care and most endocrinologists are taught in med school. And remember, if you watch Dr. Holtorf's videos, this is not a reliable test. The research has shown us from 17 years ago that this isn't even the best test. But what they're using is they're using this as a screening. So if you're in the bottom or the top 2.5% of the population, then we'll consider that you have hypothyroidism or hyper if it's in the other side. And then we'll order the rest of these lab tests. So it's really, they're really not diagnosing anybody, really, except for the people that are extreme cases, and they're probably already in the emergency room for some pretty dire condition. So let's get back into it. That's the normal value. So I'm going to talk about what we look at typical optimal and healthy values. And this isn't just here. This is pretty much standard now with doctors who are in tune and who are looking to really help improve the health of their patients. Here's the thyroid gland. Remember I said it sits at the base of the neck. So it makes two hormones, T4 and T3. T4 is a tyrosine with 4 iodine molecules on it. Okay, this is a large molecule. It's a little too large to get in most of the cells. By the way, I'm always oversimplifying the science here. It's a little too large to get into the cells. What needs to happen is an enzyme comes along and it breaks off one of these iodines and it turns it into T3. T3 is the good guy. T3 is the one that's the key. It travels all the way through the bloodstream, going to every single cell in the body. It goes right into the cell, locks on the receptor site in the nucleus, and turns it on. Remember? So every cell in the body now functions properly. So why does the body make some T4 and some T3? T4 is a little bit like a preparatory or a storage or a prohormone. It's a little bit like buying 4 gallons of milk and keeping them in the freezer, right? We've got this storage form ready. It's not drinkable till we take it out of the freezer. We wouldn't want to open every one and pour glasses on the counter. So we wouldn't want it to be all sort of this active hormone. We have a storage prohormone, and it serves that purpose. This one stays in the body longer, and then it converts as needed to T3. This is how our body functions. We make about 4 times T4 to T3 on a daily basis. So we check for free T4 levels. Now the normal ranges are, but we really want to know, is it converting? Since this one, it's like having the storage form. It doesn't do any good until it's unbound and then it can get into the cell. So then we look next at free T3. I'm looking at normal ranges for most labs. If you have your lab test at home, you can look at these. If the numbers look way off, there's probably a different parameter they're using. So don't take this too literally if your labs look different. So the T4, the enzyme will break off and turn this into T3. And this is the good guys. I said they can get into the cells. Now there's another phenomenon that is happening here, and this is a little bit like putting the brakes on. This serves a purpose. We don't want our body to be hyperthyroid. So if your body sees too much T4, there's a few other reasons, but if it sees too much of that, instead of converting to T3 and going right down this healthy, active route, it'll create reverse T3. Reverse T3 can go in. It does 2 things, is that it can block T3 from getting into the cells, and basically what it does is what happened here is the different enzyme came along and it broke off the wrong iodine. It broke off a different one. So we've got 2 mirror images of of a similar molecule. So this looks a little bit like T3 as well, and it goes in and it actually can also lock onto that receptor site, but it doesn't do anything. It's a little bit like sticking a paper clip in a lock. So it's blocking. It's basically like this is a foot on the accelerator and here's a foot on the brake. So what we found is that we want to see an optimal ratio of free T3 to reverse T3. And that ratio and I'll explain this in a second, is 0.2 to 1. It's a little easier than you think to look at that. So these are the active hormones. This is the best indication of whether the thyroid is producing enough hormone and whether that hormone is getting into the cell. Sometimes it's really not theoretically hypothyroid. Your gland might be producing enough, but there's some processes that are happening in the blood that might not be functioning well. So this might be sort of the scene of the crime, but to oversimplify, it doesn't really matter. You're having symptoms of hypo or low thyroid function. So what we look for here is most people with the TSH, they really don't feel well unless this number is under 2. This is when you're not treated, okay? So it means that the thyroid, if this is up at 5 or 10, it means you're brain is screaming at your thyroid to do its job. So that's hypothyroidism, because the thyroid is being lazy and not functioning right. So that's our first, but again, it's not a screening, because if we found out that TSH under stress, dieting, aging, infection, any other stressor like that, the TSH does not respond very well. Theoretically, it's supposed to respond by the amount of T4 and T3 going up. If it sees enough, then it says, okay, I don't have to yell at the thyroid to do its job. However, as we said, also the pituitary has different functions. So it basically sort of takes the active hormone for itself, and it doesn't really care or know about what's going on in the rest of the body. I'm giving a lot of sort of playful analogies so you can get a feeling for all of this. So that's the TSH. We want to make sure that's not screaming at your thyroid. And they're not even really talking in a very loud voice, right? T4, again, it's a prohormone. We find that this one, it doesn't need to be too high. If it's quite high, it's usually not converting very well to T3. Again, it's like having too much of that frozen milk in the refrigerator. We want to make sure that we're pulling some of it out in the single vials every day. So this number, I like it somewhere around maybe 1.0, maybe a little bit less. This one is just going to give us an indication where the thyroid's functioning at all. Then what we look for is this active hormone. So free T3, most people don't feel well until this number is over 3. So again, it's kind of pushing towards the top half of this lab value. Because if this were down at 2.1, that's the bottom 2.5% of the population. Even 2.5, you're at the bottom maybe 5 or 10% of the population. Who wants to strive for that in their life? And then reverse T3, right? It's like having a foot on the brake here. So we don't want this too high. So this number, this is usually, there are different parameters they do. I'm just going to oversimplify it for you. Usually this number is in the teens, so this might be something like, let's do here, 15. And let's say your number here is 2.0. So you've already got some low T3 going on, you're 2.0. So you barely have a foot on the gas. And then you're also creating a fair amount of reverse T3. So you've got to hardly put your foot on the gas, and you've really got a foot on the brake. This ratio, if you want to take out the decimal point, it's because it's in different parameters with deciliters versus the different parameters. So free T3, if you take out the decimal point, this is 20. So we don't want your reverse T3 higher than 10. Right, so it'd be 20 to 10, because I gave you this ratio. It's basically, you can even look at it just a 2-to-1 ratios actually. This is the way I like to teach people, is that take out the decimal point, and then we want free T3 to be twice the level of reverse T3. So right now, 20 to 15, it's barely over a 1-to-1 ratio. So every time we've got a foot on the accelerator, trying to get moving in our lives, we've got a foot on the brake. And that's the way most of you feel if you've been hypothyroid and you've been trying to explain this to your doctor. So now we've got laboratory proof. So we've listened to your signs, we've observed your signs, we've listened to your symptoms, we've done some advanced testing, we've seen what your basal metabolic rate is, we've seen whether you have enough iodine. So remember, this was a tyrosine molecule with 3 or 4 iodines on it, so you need iodine in the body to even make this hormone. We've looked to see if your gland looks like it's functioning properly, and now we've got a full panel of labs. Now there's a couple other labs that we need to look at that's part of this panel. And these are the antibodies. So we've got 3, it's the anti-thyroglobulin antibody, anti-thyroid peroxidase enzyme, and thyroid stimulating index. So these are 3 antibodies. What are antibodies? When your immune system sees something foreign, a virus, a bacteria, a parasite, anything like that in the system, kind of a foreign invader, the immune system creates antibodies to attack it. In this case, your immune system is attacking your own thyroid gland or one of these molecules, depending on where it is in the process. This is not good, right? It means that your immune system is like the soldiers infighting. So these are really important tests to do, and these will help us diagnose you with either Hashimoto's hypothyroidism or Graves' hyperthyroidism. They're actually two sides of the same condition. In young girls, we'll sometimes see Hashimoto's come first, so the immune system is attacking the thyroid gland, and so it's spilling extra thyroid into the blood. And so the blood now has too much thyroid, then we get those hyper symptoms we talked about. And then what usually happens, though, is that immune system is attacking the thyroid gland, and then it starts degrading it. So then we get into hypothyroidism. By the way, so I've had patients come too and they say, oh, they diagnosed me with hypothyroidism, but I say, did they do these labs? No, they just said it's always that way. Well, we really can clarify whether you do or don't have it with one condition. There's an expert I know who just spoke about this recently, and he was talking about that we have 3 ways of measuring this autoimmune disease in the thyroid gland, but apparently there's 12 or 13 other antibodies that we don't know about, we don't know how to test. So, we have to take lab tests with a grain of salt, but this is one glance into our bloodstream and we can find out what it is that if our immune system is attacking. Now, why would our immune system attack us? We have a couple reasons. One is whenever there's dysfunction in the body, the immune system gets involved. So it's a little bit like we have a robbery and then the fire chief comes too. It's like it's just a dysregulation, this sort of overseeing of the body. So that's one reason why it happens. There is some correlation, possible correlation with gluten. What's the deal with gluten? I know you've heard about this, and I'll speak about gluten more in our next talk when we talk about the gut and digestion and diet. So what's happening with gluten is that gluten is it's in wheat. It's a very large molecule that we're not meant to digest. It comes into the digestive tract and it tears it up. So the digestive tract opens up, and so this large molecule gets into the bloodstream. The immune system says that's not supposed to be here, so it mounts an immune attack and it forms antibodies, right? Good thing. If it's not supposed to be there, if it's too large a molecule, we should attack it. Then we've got inflammation throughout the body. That's a whole other story. Why does this correlate with Hashimoto's or Graves' disease? There are some proteins sticking out, or some indices sticking out of the thyroid molecule that look like the same ones that are on the gluten. So you've mounted an immune response against the gluten molecule, then it looks and it sees this thyroid molecule and says, oh, there it is again. So it's called cellular mimicry. So this cell basically it's the gluten that has the cellular mimicry. It looks like the thyroid gland. So now we're attacking the thyroid gland. So I do recommend, if you've been diagnosed with Hashimoto's or Graves' disease, I do recommend you get off gluten. I'm not convinced that will completely clear up your hypothyroidism or the autoimmune factor of your hypothyroidism, but it's definitely helped smooth out the picture. Another note about, so these are Hashimoto's disease or Graves' disease. Graves' it's hyper, and Hashimoto's is hypo, with some of these antibodies high. What does that look like? What does Hashimoto's look like in comparison to just other hypothyroidism? It has a little bit more of a brittle picture. So your immune system has been attacking your thyroid gland, so you have decreased function. The gland might even be getting cysts or nodules, or it might be smaller, it might have some or larger, it's forming this goiter. So you have reduced thyroid, it's not functioning well, so it's not producing enough of these active hormones, And so you've got signs and symptoms of hypothyroidism. But almost every patient who comes in with this says, you know, I have these days where my heart's pounding or I can't sleep and I don't know what's going on. It's confusing me and it's confusing my doctor. This most likely is because your immune system is attacking the thyroid gland, occasionally spilling extra into the blood. Or it's just attacking one of the molecules. There's just this kind of dysregulation, so you're getting these moments of hyperthyroidism. Now, the only way to prove that would be if we checked your blood moment to moment. But I do see this happening, that it's a little bit more of a complicated picture. It's nothing we can't treat, but it's a little bit, as I said, more of a brittle picture. You're basically hypo, but you have these days that feel hyper. Now, how do you treat Hashimoto's? I'm going to talk about full treatment of thyroid medicine, but what are some other ways to treat if you have Hashimoto's or Graves' disease? One is, as I said, getting rid of gluten, reducing, really cleaning up your diet, getting rid of any other extra toxins. You might have some infections going on also. You need to look at that. If you have some low immune function, getting lots of colds or flus, or you just feel like you're always fighting off some chronic illness, then we have to look at that. It's a sideline contributing factor. But some basic things to do are some supplements, and actually this goes with hypothyroidism, is you need enough selenium. It's a mineral. You should take 200 micrograms a day if you are tested low, or if you find it's not in any of your diet. One of the things it's found in is Brazil nuts. If you eat about 8 or 9 Brazil nuts a day, you can get in that selenium. You also need iodine, remember? And the middle molecule here is tyrosine, so that's protein. So you need lots of good protein in your diet for healthy thyroid metabolism as well. Sometimes iron deficiency is connected here. Iron helps us do this conversion. So especially younger women, if you're still menstruating, you want to be checked to make sure that your iron and ferritin levels are normal, or that you're taking supplementation. And then there's a couple herbs that can help calm down the thyroid if it's that hyper Graves' disease. And there's some other ones that just can help stabilize it. I don't see a really great response just with herbal medications. Most people need to be on the correct thyroid dose with a couple other supplementation, and then the antibodies start to calm down. One of the most important things to add here, and we're using it a lot, is called low-dose naltrexone. Don't read about naltrexone. It's a strong drug to get people off of opioid narcotics. If you want to look up something on the internet, look up LDN, low-dose naltrexone. And it supports and modulates the immune system. It works phenomenally for any autoimmune disorder. Now again, you've got to be doing some other health lifestyle recommendations too, right? Cleaning up your diet and following some other treatment plans that we go through. Okay, so when we've done all this, and so this is how we're going to use our lab test. So if you have a doctor who's just said, TSH normal, they have not really looked further. What's interesting about this is, why is the TSH not that responsive? Here's an analogy. Think of the TSH as your parent, as the parent, and the thyroid is the kid. So the parent says to the child, do your homework. If the thyroid, you have a healthy thyroid child, the kid says, great, does their homework, shows it to the parent, shows it to the parent, right, comes back out, the parent says, great, I don't have to yell at you again. And that's the way life goes. Do your homework, just talking in a normal voice, the kid does his homework, passes back up. That's what this sort of checks and balances. What happens if this isn't functioning so well? The parent says, do your homework. Kid doesn't respond. Do your homework, right? It gets louder and louder. That's shooting this TSH up. Sometimes we'll catch that early, that you have a high TSH and then these numbers are low. So that's kind of a typical classical hypothyroidism that we're taught in the early part of med school, that's classic. But again, that's only those 2.5% of the population. So it's like the parent signaling the kid. What happens when the kid is not functioning right? So the parent is screaming at the kid's not getting up. After a while, the parent stops screaming, right? Because the kid is just lying on the couch. He's not doing his homework. So it's not so much that, so when we see this number being low, it just means it's non-responsive. It doesn't mean that the thyroid is doing its job. It doesn't mean that it's getting into every cell in the body. The other side, as I said, there are different enzymes, so the TSH is getting enough thyroid. So basically the kid has said, yes, I've done my homework, and so the parent says fine, but it's really not getting in the cells, okay? So there's all sorts of, it's this overseeing function, and as we know, communication is not always perfect. So that's part of the explanation, and we find that under stress, as I said, aging, so mainly just people over 40 and 50, this starts to not function as well. Dieting will suppress this as well, infections, and all sorts of things, and also, yeah, weight gain will also do it. So this is how we're diagnosing hypothyroidism, with really 5 ways: signs, symptoms, the advanced testing, imaging, and a complete lab panel. Now we're going to talk about treatments. This is another confusing factor, but it's actually a lot simpler than you think. In the early part of the 19th century, 1900s, armor thyroid was discovered. So what is armor thyroid? So this is the way early scientists and medical practitioners, they saw somebody with signs of hypothyroidism, and then they looked at an animal, and it happened to be the pig thyroid, that they literally took it from the pig and they took it orally or gave it to their patients. I'm sure it's always some doctor experimenting on himself. And they gave they used armor, it's just the name it was given after that. And it's the same molecular structure that we make. So it's a combination T4 and T3. Now this is porcine pig. This has been used for over 100 years. The good news about this is, so it's probably the most natural choice we have. Now natural is good and bad, right? When we talk about women's hormones, so we have Premarin. Now, if you think about it, that's more of a benign choice. It's horses' urine, pregnant mare's urine. If that's actually a nice choice, it was again started a long time ago. They made a formula out of it, and it helped correct women's estrogen imbalances. It's just that science later down the road found that horse estrogen does not match human estrogen. There are 17 kinds of horse estrogen, and there's only 3 humans. In the case of, so we say that's not bioidentical, so it doesn't have the same molecular structure as our human. There's nothing really inherently evil about it. It just, through science and education, we've learned that it's not a good match. Armor thyroid, on the other hand, is a perfect match. Even now it's been scientifically analyzed now, and it is an exact molecular match to what we make. It's about the same combination of 4 times T4 to T3. So this has been used for a long, long time, over 100 years. Then what happened, the pharmaceutical company came along and said, especially when this started to go generic, it's a very inexpensive hormone to make, pharmaceutical companies said, you know what, let's see if we can package something. We always like to turn things into a synthesized powder. So they said, let's take some armor and let's synthesize it in a laboratory, and let's just make T4 only. Right? Everybody comes in now and says, Synthroid, it's evil. It's really not. It's the same. Remember I said we make T4 and it goes down to T3 and reverse T3? It's a fine molecule. It's that storage form, actually, or sort of the pro-hormone. It works great. It converts to T3 and it gets on its way. It just doesn't work well on many people. all the thyroid choices, interestingly enough, are all bioidentical. None of them have an added molecular structure. None of them are mismatched for our human structure. They're just different combinations. So there's nothing inherently sort of toxic about any of these. They just don't work on everybody. So as I said, this seems to replicate human thyroid the best. T4 is like giving all that storage form, but we don't have the enzyme to break it off for those singular T3. Now, but again, this works on thousands and thousands of people. It's just not everybody. And then the other thing is when your doctor retests you, when they put you on some Synthroid, they retest you and they see your TSH went down, right, to that low value. And they say, oh, you must be hyperthyroid. It's a little bit like saying, gosh, the mother has not screamed at her kid anymore. Her kid must be overworking. It really has no relation. And so I'm going to tell you this really, all thyroid medications work. They just don't all work on everybody. And most people who come to see us have either been on slightly the wrong formula or sometimes just plain too low, okay? So this is, as I said, this isn't the best option because when we've got too much T4, the body says, I'm going to put the brakes on. There's too much T4 and it can't convert adequately to that free T3. It makes reverse T3. So this is where the research is quite interesting. And who makes a lot of reverse T3? Who in the population? People that have been on too much Synthroid because it just is not converting very well. And there's a really interesting thing. What is this doing? It's putting the brakes on. When do we want to put the brakes on? It's when we're under, or when our survival is being threatened. So this happens in a couple populations, ethnic populations, who've been exposed to famine. For example, the Irish and also Native Americans. The Irish with the potato famine, right? So there wasn't enough food. So think about that, not enough gas or not enough keys to turn on the whole body. So the people who had a lot of energy and a lot of energy requirements, meaning big appetites and needed to run around to fuel their body, those people did not survive because their requirements were too high. The ones that could shut down their metabolism, create reverse T3, and subsist on just a few hundred calories, those were the ones that survived. So they had this propensity to make reverse T3, and that's in their genetic offspring. So we'll often see people with Irish descent who have hypothyroidism, and they tend to make a little bit more of this reverse T3. Again, it's for survival. It's not for thriving, though. It's not for running a business. It's not for working. It's not for creating a relationship. It's not for raising your kids. But it's for survival, basically hibernation. So it keeps you lying down and just sleeping through while you heal. It's a good thing to have happen if you have an infection. It makes you sleep and rest while the immune system can take over. So let's look at what do we do here. We also have some options of T3 only preparations. So we have, now back on T4, by the way, Synthroid is the brand name. The molecule is levothyroxine, right? And then there's some other brand names too, Levoxyl, Synthroid. There's a sustained release one, which is kind of interesting. Tyrosint, it's called. But basically they're all T4. Not a great idea because your body just doesn't want it all. It wants some of that T3. As I said, you're going to have a sister or a cousin who says, I've been on Synthroid and felt fine. So it just means that they have a healthy enzymatic process that can convert well. Again, nothing inherently wrong with it. However, if you are sensitive, right, these are regular pharmaceutical medications, so they have additives and they have fillers, but they're pretty stringently, have pretty stringent requirements, so there's this certain amount of T4 in there. Before we get to this too, what's the controversy here? They said, oh, Armour is not is well balanced, or it doesn't have stringent requirements as to amount. Remember, now the thyroid molecule, by the way, this is all microscopic, so you have to have a good chemist, a good pharmacist working with all of these, and these tiny amounts make a big, big, big difference. So there was a while when there was some, again, think they were basically just kind of taking a little chunk of the thyroid until they learned to do it and weigh it out scientifically. By the way, there's the nomenclature for this for Armour is called a grain, and it's sort of like this weight of the full full medicine that includes T4, T3, and some other animal proteins in it, frankly. The other Armour, actually, my favorite one is called Thyroid. They also make another one called Thyroid, which is about the same. Or you'll hear desiccated porcine. It means dried pig thyroid. There's another brand. There's a couple other brands in other countries too, but it's basically, it comes from Armour Thyroid, and if you do want to get a clean source, that's why I really like Thyroid. They have actually a narrower requirements on what kind of variation they can have. So interestingly enough, the pharmacists who said Synthroid is better, we don't know if Armour's very well balanced, they did a study, and actually the irregularities in the medicine were found more with Synthroid. Because it's microscopic, they just didn't have stringent enough requirements. So, it's still pretty darn close. Just think our body doesn't produce the same molecular amount every day either. But actually, it's just funny where the controversy points saying, oh, Armour's not very specific and stringent, whereas actually it was really the Synthroid. And Dr. Holtorf talks about this in his webcast as well. There was a little controversy about 8 or 9 years ago, and there was a shortage in Armour, and there was a little controversy about that, and apparently when the new formula came in, most people didn't feel well on it. It's probably due to the additives that were and were not there. So, nothing's perfect, but these are some options for you. So here, what about Synthroid? What about T3? So T3, the pharmaceutical brand, is called Cytomel. There's just one choice. It's a nice option, right? Because we need some of that T4 and some of the T3. However, it's instant release. And so what it does is it's like having a shot of espresso, and that sort of idea is that it's increasing your T3 levels quickly. And T3 has a short half-life. It's about a day. So it'll still be in the blood 3 or 4 days later, but it basically is coming in and out of the blood on a daily basis. So it's not really good to do very high dosages of it, although some patients have found a tiny little dose of Cytomel has made that difference along with their Synthroid. But most doctors who are adding this in, they're not really doing great ratios. They're doing such tiny amounts. It's not usually making a big, big difference. So the other option is to have a good pharmacist compound T3, a sustained release formula. So it will stay in the blood for a full 24 hours. Now I'm going to tell you also, in the industry, most pharmacies are making them so it lasts only 12 hours. So you want to find a pharmacy that knows how to make it so it'll last 24 hours. It's a little harder to find. So that's not a bad option, because now we can get some T4, add in some sustained release T3, and we're mimicking what our body would make. Then we can also have some T4, T3 combinations. So this is in the same capsule. Now T4 stays in the blood about a week. So even if you missed a dose one day, it wouldn't really make a difference. But T3 stays in the blood about 1 day. So that one you do have to take every day. We can put them together in one capsule. If you do that, we actually don't want it to be sustained release in most cases. Sometimes we do, but it will kind of work the same as that Cytomel, but it's not a bad option because if you do a T4, T3 combo, it's done in the same ratio as Armour, which is that 4-to-1 ratio. So it's not really high levels of T3. So those are the choices. Are they natural? Are they bioidentical? Are they synthetic? Kind of a little bit all of the above. I mean, Armour, we still want it going into a chemist. We still want them to synthesize it and make it a clean, exact formula. So this is really theoretically the only natural one. These others are all compounded, but they are all bioidentical. Our body, when we see bioidentical, our body sees that molecule and it says, yes, I recognize this. This is self. I know what to do with it. I know to send it through the blood. I know to lock onto the receptor sites. So these are all the medicine options. So don't be upset about, oh, one is evil, one is good, one is bad. They are the same, and they just may not work for you, and there might be some specific reasons. So let's look at a couple kind of examples. I've had patients come in on Synthroid. So their doctor gave them, say, 50 micrograms. This is always in micrograms. And they said, oh, I got diagnosed, I was depressed, I was heavy. They put me on 50 micrograms, I was feeling okay, we went to 75, we got up to 100 micrograms and I was feeling really good. He said, I went back to my doctor and I said, I'm feeling great, I have energy now, I'm losing weight, my brain function, I finally feel like I'm myself again. And the doctor looks at your labs and it sees that TSH going down. Remember, it's just the quiet parent. It just means that we've taken over the job of the thyroid. The pituitary doesn't have to yell at it anymore. And your doctor says, actually, your TSH is too low. That means you're actually hyperthyroid, too much. So I need to lower your dose. And you as the patient say, okay, well, all right, let's see. And so your doctor lowers you back to 75 micrograms. And then I've seen this happen time and time again. Patients come to me and they say, I felt great on 100 micrograms. They lowered it back to 75. Now I've gained weight again. I went back to my doctor and my doctor said, it can't be the thyroid. Here's an antidepressant, or you must be eating too much. So it's not logical. We're not listening to the signals of the body. We've got to listen to the body. This is our body talks to us through these signs and symptoms and through our blood tests. So that's an example of Synthroid actually working fine, but just being the wrong dose. Again, I would never start anybody on Synthroid. There's no reason to, but if somebody's on it, we can kind of work with it. There's no reason to give you something that's not the same molecular structure that we make. Another example is somebody's been on Synthroid, and then they were switched over to Armour. Right? Good idea. Let's get a little bit more Armour or Nature Throid. Let's switch over and let's give you a little bit more of a bioidentical structure and let's see how your body responds. Now, this takes a little bit of math. I'm not going to go through the numbers now, but you have to know what you're doing with this. So if I give you a high dose of Synthroid and I say, oh, we'll change you to Armour, I've had a lot of patients come back and they say, oh, that Armour stuff didn't work for me either. It's usually because they switched and they went on a lower equivalent dose of Armour. So it's not that the Armour didn't work, it's the dose was too low. So you've got to have a doctor who will watch your signs and symptoms, see you pretty much every month at the beginning with lab tests, maybe not every single month, but every couple months with lab tests, and listen to you. If you say, oh, I'm feeling much better now, and then we make sure if your dose is too high, you're going to have these hyper symptoms. I say this to my patients at every single visit, whether we change your dose or not. I say, if you have any of the following symptoms, increased heart rate, shakiness or jitteriness, a tremor, increased digestion, maybe diarrhea, headache, and mainly that increased heart rate, or quickly losing weight, or lying awake at night with insomnia. If you have any of those symptoms, there's symptoms of hyperthyroidism, it means that your dose is too high. Stop it entirely for 2 to 3 days while you call us, and then I'll lower your dose a little bit. Some people, I do this at the beginning when I'm introducing thyroid medication to them, your body will tell us. It won't do any long-term damage, but it's just not a good idea. It's like drinking too much coffee. We need to get out of the system in a couple hours, and then your body will handle it. The other thing that can happen is you can be on your great dose of your thyroid medication, and 2 years later, all of a sudden you start having symptoms. Maybe it's because you've lost weight. Maybe it's because your hormones and your adrenals and everything else has been balanced. So it just might mean that you don't need as much then. Or another sign is if you lose weight. So you have less body mass for the medication. And some people actually need higher dosages in the winter when they're feeling a little bit more fatigued. In the summer, they're out in the sun, they're getting a lot of vitamin D, they're exercising, they're eating well. So there are a lot of different factors. Because T3 has a short half-life, we want to keep a check on you, check it every couple months. So so that's the person who's come in and they've been switched to Armour and say, oh, that stuff didn't work either, nothing works for me. It's really just that your dose is probably not high enough, and that we weren't getting those good levels of free T3, and maybe you were making too much reverse T3. The other thing we'll do is if somebody comes in on Synthroid and they're feeling quite hypothyroid still, when I do their labs, what I usually see is that your T4 levels are pretty high, your T3 levels are low, so it's not converting well, and that reverse T3 level is quite high. So in other words, for you, the Synthroid's not working. So usually what I'll do if I have those kind of lab results is I'll start lowering the T4, and then I'm going to start adding in some T3. And so in this case, we'll use a sustained release T3. So it's a great formula to add in, especially if somebody's on a high dose of, say, Synthroid, 100 micrograms. Some people on higher dosages, don't worry about where you fit in. It's what your body needs. Some people do great on a low dose, some people need higher doses. Don't worry about that. But somebody's on a fairly high dose or a good solid dose, they're not getting good response, I'll start lowering their T4 a little bit, and I'll give them tiny little doses of T3, the sustained release. I might start with 2.5 micrograms or 5, or maybe get up to 10 or 15, and I'll start working in this direction. If I get you to a 4-to-1 ratio, which is again that ratio that we make, then I might put it in one capsule, or I might switch you to the Nature Thyroid. So we have lots of ways of working, and everybody's different. We're pretty good at noting kind of what pathway we think you're going to go, but the body will respond, differently from everybody. So we might need to adjust your dose. As I said, then we start introducing more of this active hormone in the body, reducing some of this so we get a better ratio. Interestingly enough, when we do that, sometimes on your first blood test, if I give you some T3 and reduce your T4, T3 instead of going up, it actually goes down in the blood. And why is that? Because it's getting into the cell, not hanging around the blood anymore. So it's kind of a paradoxical response that we get from that initial treatment. So that's a pretty good number. I didn't really go through any numbers with you. It's not necessary, but all the choices are good. You want to find an integrative medical practitioner who understands all the facets. If it's pharmaceutical, might be fine, or compounded might be fine, or maybe herbs or supplements will be fine for you. So you want to make sure you've got somebody who's broad-minded and smart and knows the literature and knows the science to do all this. So that's a pretty good overview of your thyroid disease. I want to talk to you just a little bit about fatigue, right? Thyroid, since it's the main driver of our energy, it really is the first thing we look at if somebody's fatigued. But if you're not sleeping right, no amount of thyroid is going to cure you. So we've got to get your sleep under control. Either you just need to sleep more, or maybe there's something else going on. We've got to check your adrenal function as well. And if you're 40 and older, really we got to check your female or your male hormones. That, especially with menopausal women, not having enough estrogen can just feel like this deep bone tired fatigue that you just feel old without adequate levels of your hormones. It's really our life force. So thyroid is not the only answer. The other thing is that if you have any infections in your body that you probably didn't even realize it. We're seeing it a lot with chronic fatigue and fibromyalgia. We're seeing a lot of people with Lyme disease that basically dysregulates the whole thyroid picture. So sometimes we give you thyroid and you just still aren't feeling better. But we know it. We've optimized your levels according to your signs and symptoms, not just from looking at the TSH. And but sometimes I said your symptoms will get sometimes even worse on thyroid. If we give you a little bit of thyroid and you feel much worse, sometimes it's because it's kicking up a latent infection that you have. So we see this with Lyme disease and some other chronic fatigue pictures. So we've got to treat you really comprehensively. We've got to look at your thyroid. We have to look at mitochondrial function. We've got to look at adrenals. We have to look at your female and male, the sex hormones. Look at your general state of your immune health. Are there underlying viruses, bacteria, is there yeast, things like that. And then there's really no way around it. It's non-negotiable. You have to have a healthy diet. When you get enough energy, we want you exercising at the beginning. If you're too fatigued, don't push the exercise. It's just going to kind of degenerate you further. So remember that none of these, that's why I'm doing this whole sort of spectrum of this, kind of the wheel of health, really looking at every aspect of our health, and that you've got to see a practitioner who's willing to look at all of these simultaneously for you. So on closing, I want to leave you with a couple key points. One is, do not settle for anything less than optimal health. If you're having symptoms, it's your body's way of signaling you that something is wrong. So listen to your body and track your symptoms, especially if you're female. You tend to have them on sort of these monthly cycles that might be related to your hormones. Men too, though. You might be having some, especially if there's infections going on, we might have a little cycle going on with that reproduction of that bacteria or the virus. So listen to your body and obey it. Find somebody who will also listen and will adjust it accordingly. If you find your doctor, if they minimize your symptoms, if they don't believe you, if they say that can't be, you must just be depressed, and they just give you an antidepressant, find another practitioner. It's just, you've got to find somebody that will work with you. You need somebody that will partner with your health, and somebody that, as I said, will believe you. And really, don't settle for anything less than optimal health. Even middle age, there's no reason for you not to feel like you can accomplish your purpose in life. And most of us middle age are discovering a new purpose, so you do need to do some inner work as well to figure that out and to find it. But again, thank you for joining me here today and also at home. I look forward for comments and questions on what we can always answer those. And we also do consults. I can't prescribe over the phone without seeing you in person, but we can do some consultations. I can work with you and make sure you get, all these, get a full lab panel when you go to your doctor. And if you come to see us, we'll treat all of this. So thank you very much. It's been a pleasure, really my honor to help you optimize your health. Thank you very much.
I'm so excited. I finally found a real thyroid specialist. So now I actually understand what TSH is, thyroid stimulating hormone. And she actually focuses on other things rather than just telling me to test for my TSH and give me Synthroid. She actually gives me T3, which is not math. It's actually the active hormone for the thyroid. But I'm still going to check Twitter on that.
Thank you for joining us tonight. We hope that you enjoyed the presentation with Dr. Nancy Evans. If you have any questions, we have several new patient consultants that you can call here at the Holtorf Medical Group, and we would be happy to speak with you. So feel free to call us. Thank you very much.